Where is the
Dr. Prabhakar, already we are running short of time.
No, where
Please
is the
make it
presentation?
fast.
I'm seeing the presentation, sir. I'm not getting the presentation here. Yeah. No, I'm looking for the presentation. Wait. Yeah. Okay. Good afternoon. So I will be discussing the pathogenesis of CKD MBD in three main categories like definition and physiology of basic components involved, and finally pathophysiology. Coming to the discussion, the definitions already discussed. It includes it's a systemic disorder. It's manifested by abnormalities of physiological parameters like biochemical parameters like vitamin D, calcium, phosphorus, and abnormalities in bone mineralization, volume, and linear growth, and extraskeletal calcification like vascular and soft tissue calcification. Either of the above or in combination constitute CKD MBD. Excuse me, just a moment. Where's slide share, madam? Slide share, slide sharing. Slide sharing button. Slide share. Slide share పెట్టండి యానిమేట్ చేసాం కదా ఇట్ హాస్ బీన్ యానిమేటెడ్ జస్ట్ బ్యాక్ ఇలా కాదు స్లైడ్ షేర్ కావాలి నాకు ఇది రాదు యానిమేట్ చేశాను ఇంకో తర్వాత వస్తుంది anyways I will take care. Actually the slides are not being projected properly over here. Let me talk. So first parameter is parathormone. The regulators of parathormone in body are especially calcium and calcitriol. This is active vitamin D. Parathormone acts on bone and by combination with parathormone receptor it activates various intracellular signaling pathways, out of which WNT and beta-catenin helps in formation of bone, and rank ligand helps in bone desorption through osteoclasts. The other component is FGF23. It is mainly produced by osteocytes and osteoblasts. It acts at proximal tubules where it inhibits 1-alpha hydroxylase and by decreasing serum calcitriol levels. It also inhibits sodium and phosphorus channels at proximal tubule, thereby inhibition of renal phosphate reabsorption. So another thing here I want to mention is about clotho, as already Sir mentioned. The clotho is a co-receptor to FGF23 receptor. It is expressed in proximal tubules and distal tubules, osteocytes, parathyroid gland. It negatively regulates FGF23 and it decreases in kidney injuries, and loss of membrane bound clotho leads to continuous production of FGF23 from osteocytes. The other is calcitriol is active vitamin D3, and everyone knows how it metabolized in the body from ultraviolet light to kidneys. The target organs of vitamin D3 are bone, intestine, and kidney, and is mainly regulated by parathormone and phosphorus. And phosphorus, 85% of the phosphate can be found in skeleton, and it is regulated by vitamin D, parathormone, and FGF23, which is called as phosphaturic peptide. And also in this picture you can see the metabolism of calcium. The major hormones involved in calcium physiology are calcitriol and parathormone. So with this I am shifting to pathophysiology. As Sir already told, it can be explained with the concept of trade-off phenomena, which is nothing but giving up of one thing in return of another. So to maintain serum phosphorus and calcium levels, other entities like parathormone and FGF23 jeopardize, which leads to end result. So before the discovery of FGF23 in the role of CKD MBD, the classic trade-off phenomena was hypothesized. In this, with decrease in nephron mass, the phosphate clearance will decrease, thereby the serum phosphate will increase. With that, it increases parathormone with various mechanisms, out of which the calcium is, hypocalcemia is one of the mechanism. The phosphate will bind to ionized calcium in the body, thereby decreasing the calcium, which is very sensitive promoter of parathormone. And phosphate also inhibit 1-alpha hydroxylase, thereby decreasing calcitriol levels and thereby decreasing parathermone. There are mechanisms how phosphate increases parathermone is by non-competitive inhibition of calcium sensing receptor and also inhibition of vitamin D receptors. With the discovery of FGF23, the updated trade-off phenomena was hypothesis, and it is categorized into two phases, the early CKD phase and late CKD phase. In early CKD phase, with reduction in nephron mass, here you have to see the decrease in phosphate clearance. It is not hyperphosphatemia. So with decrease in nephron mass, with decrease in phosphate clearance, the FGF23 levels will increase, and FGF23 in turn reduces the calcitriol levels by inhibiting 1-alpha hydroxylase enzyme. So the reduction in calcitriol will leads to hyperphosphatemia, the hyperparathyroidism. Whereas in late phases of CKD, again the hyperphosphatemia will lead to hypocalcemia and it reduces the calcitriol levels and leads to hyperpara. So in CKD, primarily we see secondary hyperparathyroidism, and later on it becomes maladaptive because of the resistance. The resistance is because of the reduction in parathermone receptors and oxidative modification of parathermone and increase in progesterone levels and various mechanisms. Tertiary parathyroidism usually seen in ESRD patients in which the parathyroidism hyperpara is associated with hypercalcemia. Histopathologically, you can see nodular hyperplasia or adenoma. In tumorous tissue, the calcium sensing receptors and vitamin D receptors are reduced. Abnormalities bone. Traditionally, the biochemical parameters like parathermone and bone-specific alkaline phosphatase were used to categorize bone abnormalities. However, in 2006, KDIGO suggested to do a bone biopsy to classify renal osteoid dystrophy based on turnover, mineralization, and volume. Here, the turnover and mineralization are dynamic measurements of histoformometry, whereas volume is a static measurement. So with this, the renal osteoid dystrophy is categorized into 4 different varieties like osteomalacia. Osteitis fibrosa is nothing but high turnover bone disease. Adamic bone disease or low turnover bone disease, and finally mixed osteopathy. The next is extraskeletal calcification. So mainly I will discuss vascular, intimal and medial calcification. Intimal calcification is nothing but atherosclerosis. The risk factor and pathogenesis of atherosclerosis is out of this context. And I will be concentrating on medial calcification, which is majorly related to chronic kidney disease. So what happens in chronic kidney disease, the balance will shift to the promoters of calcification. The promoters of calcification include hypercalcemia, hyperphosphatemia, hyperpara, and oxidative stress. So with the tilt in the balance, actually what happens is there is a transdifferentiation of vascular smooth muscle cells to osteoblastic cells, thereby creating a milieu which can form calcification in vascular media. The another emerging concept in the pathogenesis of CKD mineral bone disorder is WNT and beta-catenin pathway. Actually, the studies are still underway. So in an attempt of kidney repair, the various developmental programs been activated, out of which WNT and catenin pathway is one of them. With the continuous activation of this pathway, the inhibitors of the pathway will be released into the circulation. The inhibitors are like DKK1 and sclerostin and others. And what happens is these inhibitors, after releasing from the kidney, they act in an endocrine manner at various other organs like heart, bone, and vascular system. So this picture shows how the WNT-catenin pathway acts. Though by combining with combination of receptor like Frigil and LPR56, the WNT activates beta-catenin. With translocation into nucleus, it activates various genes which are responsible for bone turnover, vascular calcification, and myocardial fibrosis. So through Wnt signaling, parathermone helps in bone formation, and Wnt signaling through FGF23, parathermone hyperphosphatemia, they promote extraskeletal calcification. So with prognosis of CKD, as I already mentioned, the release of WNT inhibitors, actually that reduces bone formation, and that's why leads to adenamic bone disease. Theoretically, Wnt inhibitors should inhibit vascular calcification. However, studies showed the other way around. For example, I have picked this table from one study, which has actually it's a rat model. They used monoclonal antibodies against the Wnt inhibitors like sclerostin and DKK1. So it shows if you see the bone turnover has been increased and also the vascular calcification has reduced. So this is the emerging mechanism, how still studies are going on. It is in on the animal models, human models still has to emerge. With this, I will conclude the topic. Thank you.